welcome to the EMSNation podcast. I'm your host, Faizan Arshad. We have reassembled our esteemed panel, and we had a day that was jam-packed of amazing critical care and resuscitation education. And without further ado, we are going to jump right into it because there's a lot to say. Starting off the morning was none other than our Swedish professor, Dr. Fredrik Granholm, talking about return to spontaneous circulation, high fives all around. However, what do you do now to optimize the transport of your post-cardiac arrest patient?
Hey Faizan, it's Fullagar here, and I think that this talk was just outstanding. I think in general we have a feeling that once the patient has achieved ROSC, the stress level amongst us tends to sort of go down, and in essence we sometimes will lose a little bit of our edge. But one thing that Fredrik mentioned is that once the patient achieves ROSC, that's really when the work starts. So the post-cardiac arrest syndrome, this concept, essentially describes this as a multi-system syndrome in that it affects the brain, the heart, it affects many systems. And our goal is to manage the syndrome and stabilize the patient. We want to prevent the patient from going into cardiac arrest again, and we want to maximize the chance that this patient is going to be discharged neurologically intact. So the first thing to consider is that of post-cardiac arrest sedation. What are your choices? What are the best things for the patient? There are a few options that we generally have available to us. It seems to be that the benzodiazepines may not be quite as good in this situation as the non-benzodiazepines. The other thing that's so important to keep in mind is the O2 and hyperoxia. We want to try to avoid that. The goal is to stay on the lower end of about 94 to 98% SpO2. We certainly know that free radicals, oxidative stress can be very bad for these patients, so we really have to be mindful of that. Along with hyperoxia, hypocarbia is bad as well. You may have a decrease in the cardiac output. You may have cerebral vasoconstriction. That decrease in cardiac output is oftentimes a secondary to increase intrathoracic pressure with positive pressure ventilation and decreased venous return to the heart. So we want to aim for normocarbia, approximately 35 to 40 or so. In addition, we have to take steps to protect the lung. So we want to keep an eye on the tidal volume to stay on the lower end of the 6 to 8 milliliters per kilogram. We want to keep an eye on the PEEP, again on the lower end of the 4 to 8 centimeters of water. We really want to prevent these patients from getting ARDS, and by doing so, it can actually be easier to get them off the vent. There were a number of other things discussed in regard to optimizing preload, appropriate fluid hydration, the use of inotropes, and making sure that we try to achieve our optimal blood pressure. Generally, with a mean arterial pressure, we want it to be between about 65 to 80 MAP. We never want it to go below 65, and generally we want to aim for about 70 millimeters of mercury for our MAP. So in summary, there are really a lot of things that we have to consider. The work really does start once the ROSC occurs, and there are a number of different things that are going to affect our patient both positively and negatively that we really have to concentrate on.
Chris, that was an amazing summary. Our IPP does it again.
Yeah, you know me.
Next up in our morning, breakout one, we had Charles Kircher speak about Impel to Improve, practical and logistical considerations in critical care transport of patients supported by ventricular assist devices.
So I'm a little biased as Charlie is my colleague in Cincinnati, but The main idea is that Kircher brought up the fact that it is likely that we are going to be seeing a lot more Impella runs since they have an FDA indication for protected PCI. This is going to become a higher volume thing than it is right now. And I think I can sum up his main point in a quote where he said, if you've got a CMAC, you don't watch a CMAC video on YouTube and consider yourself trained to deploy the CMAC in the pre-hospital environment. You break the thing out and you practice it in the cadaver lab and in the sim lab. You make a checklist. You should do the same for your Impella. If you're just watching the manufacturer's training online and considering yourself trained and ready to go, you're going to have problems.
Excellent. Next up, we had none other than the esteemed Charles Shepard, who recently won the award of Missouri ACEP Physician of the Year.
Dr. Shepard totally delivered with this. He started off with death by ventilator and other ways to kill your patient, which is pretty interesting. He talked a lot about resuscitating before you intubate your patient and how our goal is to maximize our O2 reservoir prior to intubating our patients. He had some pretty interesting statistics about non-rebreather masks and how, we always say 100% non-rebreather, but really it's only 60 to 70s because some of the O2 leaks out. And then once you go ahead and add your nasal cannula, then you can get greater than 90s, which is pretty interesting. He talked about how in an acidotic patient, we really need to try to match their pre-intubation PCO2s and their respiratory rate, especially after we intubate them. He also made a pretty funny comment about not to use a BVM after you intubate these patients because you'll probably ventilate them at a rate that's close to your own heart rate. He talked about having our goal for our SpO2 to be 88 to 92% and to really focus on plateau pressures for COPD patients because most likely our PIPs will be really high, but it's the plateau pressure that really matters and we need to try to keep that below 35. So all in all, it was really good high-yield tips for intubating and for ventilator patients. I got a lot out of it.
Amazing. Next up in the morning, we had Dr. Michael Jason back. Sepsis 2017, what do I do now?
So on Twitter, Jassenbach uses an avatar that says Advocatus Diablo, which is exactly what he is. He is delightfully skeptical and rigorous about evidence. And he delivered an outstanding summary of the current evidence in sepsis management. Much of it was the importance of delivering timely fluid resuscitation, timely antibiotics, not waiting until the patient has 17 liters of crystalloid on board before we go to norepinephrine. But most fascinating to me was his discussion of Paul Merrick's purported cure for sepsis. And this was new to me, which is a case series of 47 patients who Dr. Merrick apparently gave a cocktail of vitamin C, hydrocortisone, and thiamine to, and decreased mortality from 40% to 8%. Certainly, Dr. Jassenbach did not advocate that this is enough evidence to change our practice, but it is just absolutely fascinating if this could truly have anything close to that much efficacy. More to come on that.
Did he share any proposed hypotheses?
He probably did, and I wasn't smart enough to follow them, or I was too busy tweeting.
All right, so that's great reason to come to CCTMC 18, so you can get all of the devil's advocation in person. Next up, we had one of the most fascinating talks of the entire conference, a good friend and colleague, Zafar Qasim, on Raboa, Lessons from the Front Line.
I just got to say, as amazing as all of these talks that we've been discussing are, this is flat out the best talk of not only this conference so far, but maybe the best talk I have ever seen in my career at any conference. Zaf Qasim, what do you guys think? He spent probably 40 hours making that slide set. It was like Steve Jobs in terms of the artisticness of the slides, let alone the topic at hand, at which he is truly a world expert on. What did you guys think? I think one of the other main takeaways is that Zaf, who is not a surgeon, but is an EM critical care guy, effectively advocated for the fact that Raboa can be effectively delivered by non-surgeons. This is within the skill set of the emergency physician. ER docs can learn to do this procedure. And interestingly, he also advocated that in the future, even if this procedure may not be done by nurses and paramedics in the future, they could set a patient on a facilitated path to getting a REBOA by placing a femoral art line, and that is within their skill set. So that was an interesting take.
I thought it was really awesome about how he explained how REBOA can actually be, like you mentioned, proactive before the patient's actually lost their vital signs. Unlike when you're doing a thoracotomy and you're just cross-clamping the aorta after the patient's died. So this is something we can do while they still have their vital signs to keep them more stable.
Yeah, I agree. I thought it was a really excellent talk, and in two facets, both in the data that was presented as well as Dr. Hinckley had mentioned, kind of the style and the polish of the talk. I mean, he probably had 100 slides, and he stood in front and he clicked through all of them and hit every point exactly. And I don't think he turned around once, so I don't even know how he knew what slide he was on. He was just that good. And I felt probably the most important point he made for me was that the data is looking like at the least REBOA is non-inferior to thoracotomy and cross-clamp of the aorta, right? We're not necessarily saying it's better, but if it's inferior and it's easier to do, or it's has lower complications, which is what it appears to be, then that can be an indication for the future, as well as what Cynthia just said, and the fact that it can be done proactively rather than reactively.
And I think just in general, this is an important demonstration, an important example of how we can give a synopsis and we can give information here, but there's nothing like actually being here at the conference, not only to see how the presenters present, but to be able to talk and interact and network with people. That's something that we can't do on any podcast.
Moving to the afternoon today, we had our Scottish retrievalist, Dr. Stephen Hearns.
I have the pleasure of knowing Dr. Stephen Hearns, son of Scotland. I've had the pleasure of going to retrieval for the last 4 years, actually spending time with the emergency medicine retrieval system in Scotland. And they are a machine. This idea of cognitive offloading along with training, because when you think about it, training is cognitive offloading. The more you do, the less you have to think about things. But certain things he brought up that they do, they have an exquisitely developed app that they can pull up on a cell phone for almost any aspect of their operations, from standard operating procedures to even just equipment, how to operate certain equipment, how to turn it on and off if you're not familiar with. So I thought that was great. They brought up their idea of their badge cameras and using those to critique and do QA on various types of intubations, various procedures, and general interactions. And also the HIPAA and type security type issues that come up with filming patient encounters like that. So overall, again, a great speaker, and it was a pleasure to have him here.
I just want to point out how cool it is that we've just discussed two international experts that spoke here today. Speaks to the quality of this conference. There were two quotes that I think really summed up Stephen's talk. One was, getting the predictable right allows you to manage the unpredictable. And the second was, you can achieve optimal performance by the aggregation of marginal 1% gains.
There's one more quote I like that he talks about, whether it's a skill set or equipment, you have to think ahead, and if you've not brought it, you've not got it.
Well said. Mike, you carried the torch and followed with vascular catastrophes, diagnosis, treatment, and transport considerations.
Yeah, that was just sort of a potpourri when you think of all the different types of vascular catastrophes. I picked a couple. I think the first one I talked about was junctional hemorrhage, and I presented sort of a novel idea in a case that I had several years ago, only to find out that sort of newer special forces are actually using a similar technique. So with junctional hemorrhage, again, it's very difficult. It's in the axilla, it's in the groin, base of the neck. And so if you can compress it using a spherical object, I don't recommend cue balls, but something in this one kit the Special Forces developed, they actually carry lacrosse balls. And they're about the size of a tennis ball, a little bit smaller. And those can be, obviously covered, then inserted and can really give optimal pressure to control hemorrhage. There's also several other devices out there. Talked about thoracic dissection, which can be a tricky diagnosis sometimes. It's not always like abdominal aneurysms or MIs. I had a patient who had a classic example of a anterior MI, and just by luck, I happened to take a look with POCUS that I was trialing a Lumify, and sure enough, he had a large pericardial effusion, which about the only thing in that case would have been a type A dissection, which he had, so we abruptly changed his treatment course. So the idea of using POCUS and being very suspicious with people who have CVAs and MIs, and the key thing is not to anchor, your diagnosis. We do that in emergency medicine because of all this pressure for door to balloon time. Once we see that STEMI, any other possible diagnosis goes out the window. Keep a wide diagnosis. Thoracic dissections can present as STEMIs. They can present as CVAs. So keep a wide differential.
Excellent point. And you also gave a shout out to our friends across the Atlantic who we have tremendous respect for, the ATTACK faculty, anesthesia, trauma, and critical care. You recently came back from their 3-day course, Mike. You want to just give them a shout out and tell them about your experience?
Really, it was an amazing course. It was an intense, busy 3 days of trauma lectures by some of the best in the UK. We had an international faculty, an international student body there. I can't say enough about it. Their website is atacc.uk.co, I believe. But the big thing is they have probably one of the best pre-hospital trauma reference documents, their manual for paramedics, for doctors, anyone who does business in the pre-hospital environment. And unlike ATLS, which is updated every 4 or 5 years, this is updated every 6 months. It is a continuous work in progress, and I highly, highly recommend that you go to the website and download it. It's a great document.
Thanks for that reference. We'll definitely link it up in the show notes, and we strongly encourage folks to check that out and participate in the actual course if you have the means to get out there. Following, we had our 2 young HEMS professors, Dr. Drew Cathers and Dr. Mike Steuerwald, on, of course, logistics and advanced procedures in helicopter EMS.
Is there anything more important than logistics? Really?
0% chance.
My man. So this lecture Drew and I gave, we were honored to deliver it. We really love to talk about logistics when we come to this conference because it is such low-hanging fruit with respect to making those 1% marginal gains. The bottom line with respect to our talk was that we were interested in discussing an advanced procedures kit that we're putting together for our service, meant to really streamline the process when we go to do a low-frequency, high cognitive load procedure like a thoracotomy or a canthotomy or an escharotomy or a perimortem C-section, et cetera, and we just talked about our experience. I really love hearing about how other services try to solve problems within their own teams at these conferences. I think that, honestly, those are the lectures that help the most when it comes to thinking about how to solve problems for our own team. So it was a lot of fun to deliver that lecture.
Yeah, I think it was a lecture, this is Drew Cathers, that I really enjoyed putting together with Mike and contrasting our different styles, so to speak. And I think, one thing that we did focus on is that we made sure to provide examples of, these are realistic procedures that are fairly actually routinely done throughout the world, and that we don't think there's any reason that we can't progress forward to where we're doing these when indicated and when we think it's best for our patients, provided that we have done our homework and are educated and skilled and trained with the right logistics and the right equipment.
And we have the appropriate accent.
Speaking of accents, next up we had a unique individual, Dr. Scradish, who is distinguished because he's the only UW MedFlight physician not to be represented on social media, talking about awake intubation and clinical indications and techniques in the transport setting.
All right, thank you. This was a very quick overview presentation of awake intubation in the transport setting. We started talking about how awake intubation, the term itself, is somewhat of a misnomer, as we often will have the patients sedated, if not disassociated. We went on to talk about when to consider awake intubation, namely in a patient that is oxygenating on her or his own, and in whom we believe that bag valve mask ventilation and or intubation is doubtful. We also went through the three main pillars of awake intubation, namely that we want to keep the patient breathing, for example, not using paralytics prior to actually seeing our airway. We also will always want to topicalize the patient's airway, ideally with 4% lidocaine. And finally, we will keep the patient pleasant and cooperative using 1 milligram per kilogram of ketamine.
I think we're going to get him on social media before the conclusion of this conference.
Doubtful.
Next up, I had the opportunity to speak on push-dose pressors as well as push-dose nitroglycerin. And it was an exciting topic, to be sure. By this point in the afternoon, I had been perspiring quite profusely. But nevertheless, on that tangent, really the focus was riffing on Dr. Levitan's redefinition of RSI from rapid sequence intubation to resuscitation sequence intubation. And in the modern era of 2017, there really should not be any such thing as a crash intubation. In order to optimize our outcomes, we have to focus on the hop killers, which Dr. Weingart talks about is hemodynamics, oxygenation and denitrogenation, as well as recognizing acidemia or the abnormal pH in our patients. And using push-dose pressors as an adjunct or a bridge to optimizing your hemodynamics can certainly have a great effect on their outcomes. What the literature, which is sparse, but nevertheless quite clearly shows, peri-intubation hypotension has numerous etiologies, including the underlying comorbid disease process, positive pressure ventilation, acidemia, but occurs in approximately 25% of all of RSI procedures that are done emergently. Additionally, within that subset, approximately 2 to 5% of those patients will degenerate into cardiac arrest, and not surprisingly, those folks are going to have poorer outcomes. So using push-dose pressors or nitroglycerin, epinephrine at a 10 microgram per ml to optimize your hemodynamics can have a tremendous impact on your patient's outcomes and goes a long way as an adjunct as you're continuing your IV fluid resuscitation and considering or implementing continuous vasopressor infusions. The second part of the talk was primarily math-based and was looking at push-dose nitroglycerin. Again, scarce or scant data on this topic, but the math is relatively straightforward. Most concentrations of IV nitroglycerin are approximately 200 micrograms per ml. So thus, 2 cc's of this is equal to 400 micrograms. As we know, the dose of a sublingual nitroglycerin tablet is most commonly 0.4 milligrams, which is the same as 400 micrograms. Thus, just considering a different route of administration can have a tremendous impact on our patients' afterload. So for your heart failure patients who are started on non-invasive positive pressure ventilation, as you might imagine, logistically, it's quite difficult to throw tablets of sublingual nitroglycerin as they have their face mask on. Additionally, your spray is not particularly effective. So using IV nitroglycerin can be incredibly helpful in reducing your patient's afterload.
So one thing I wanted to ask you, when we think about push-dose epi, we think about pulling up some code-dose epi and diluting it. When you're doing push-dose nitro and you're just pulling some up out of the bottle of 200 mics per mil nitro, are you diluting that or just pushing it as is?
So that's a great question, because the premise of this argument is being able to do basic math, and you have to know what concentration of nitroglycerin you're carrying. So standard dose nitroglycerin is 200 micrograms per ml, and there are also variations with highly concentrated nitroglycerin, which would require dilution to approximately 500 micrograms. And I'll link that up in the show notes so that folks can extrapolate those details and determine an algorithmic approach depending on the concentration of nitroglycerin that they carry.
One comment, we find in HEMS that when you're used to working in one institution, you get used to standard concentrations, but a lot of the pressors and all those things, when we travel to other hospitals and pick up patients that are on drips, very often they're in other concentrations. So yes, you definitely have to be aware of that.
So how, you said something about it in your lecture. How quickly do you re-bolus, and is it just quick IV push, or you bolus in it slowly? Because the reason I ask is my practice has usually been to start them on a drip at just the highest rate people will let me, which is usually 200 a minute. Mm-hmm. And then as soon as things chill out, then just really start to titrate down, which when you think about it is just repeat push boluses for several minutes kind of in a row. If you're going to do 200 a minute, I guess that's a bolus of 400 Q2 minutes over 2 minutes. So I'm just curious how quickly you'd re-bolus.
That's a great question. And my experience training was very similar to yours, Mike, is I would start patients on nitroglycerin infusions at the maximum rate that I was quote unquote allowed to. And though the evidence was anecdotal, I found that we were able to turn around patients that looked like they were destined for a tube. And almost certainly, if we were able to improve their hemodynamics and their respiratory status such that they no longer even required ICU level or CCU level care. The literature also extrapolates on this with isosorbide versus nitroglycerin. Nitroglycerin can be approximately 8 times more potent than isosorbide. Additionally, we have very interesting, though not randomized prospective data using very high dose nitroglycerin. So the doses that I was talking about during the lecture are approximately 400 micrograms every 1 to 3 minutes. But there are certain folks or patient populations with refractory acute decompensated heart failure that benefit from doses up to 2 milligrams, which is an order of magnitude of 5x, so significantly higher.
So Dr. Arshad, I could sit and listen to you for hours, but a few things that I really took away from the lecture was an overview of the mechanism of peri-intubation hypertension, and really the consideration of the underlying process, inadequate resuscitation, the direct cardiodepressive effects of the induction agents themselves, and decreased venous return due to positive pressure ventilation are all things that I think are very important to consider. And you did give a nod to the good Dr. Hinckley here in regard to the -1A, particularly definitive airway sans hypoxia and hypotension. And I think that that's one thing that is extremely important, and it's a cornerstone of what we should be aspiring to with every intubation.
Thanks so much, Chris. In the wisdom of the AMPA board, they saved perhaps the sweetest for last. ARDS, ARDS for Vent Nerds, presented by Matthew Roginski, who is completing his critical care fellowship at Dartmouth Hitchcock.
Hi, it's great to be here. Thanks for the opportunity. And the last session of the day, I really wanted to take some time and talk about in-depth vent compliance with ARDS and how we can better think about this outside of a protocol, that both pressure and volumes are related by lung compliance. So I really wanted to hone in on two concepts that, one, I think we'll be hearing a lot in the next few years about driving pressure, that a lot of us have read about and looking at the difference between the plateau pressure and the PEEP, but it's really giving us insight into what's our pulmonary compliance, and then can we recruit more or should we back off with lower tidal volumes? So I think we're trying to take that concept and what does it really mean? So when we're looking down the pipe at the next 5 years, how do we interpret those articles? And last is looking at the stress index when your patient's in a square waveform with a slow breath in, but am I over-distending or under-distending, looking at the pressure curve. So I think overall trying to link both pressure and volumes are intimately related based on your lung compliance of the functional lung you're ventilating, and how we can better conceptualize that, not just looking at a PEEP table to direct our care.
Matt, can you tell us more about the stress index and what exactly does that have to do with kale?
We talked about kale because we know it's good for us, but we don't love to eat it. And I think the same holds true when I talk and I think about and want to read about vent compliance, and when I look at really in-depth pulmonary physiology on sick patients, that I think it's important, but it's really hard to stomach at first. So the stress index is trying to look at the relationship between giving a certain amount of volume over time and what's the relationship with the pressure. So if I think I'm adequately ventilating a lung that has a stable compliance, my pressure should have a linear change, like a straight line. But if I'm underventilating someone or have it under PEEP, then I have this convex curve where I'm recruiting more lung as I'm going on, and I think I'm causing atelectatic trauma. Or if my pressure starts to skyrocket at the end of the breath, then I think I'm overdistending the lungs. While both pulmonary compliance curves and kale can be delicious if prepared correctly, I think this is an insight into what we're actually doing with the patient's lungs and not just setting something and forgetting it.
Yeah, the only point that I would make, well, 2 points perhaps. The first is, dude, you have a talent for describing that stuff in a way you can understand. So I hope you keep coming to this conference and doing it. The second is, I think that, I don't know, Hinckley usually says this, and I hope I quote him correctly, but when you come to this conference, you are not trying to teach physicians and medics and flight nurses and others at a different level. You're trying to teach your best team members at the highest level you can in the same way, so everybody's talking on the same page. And I think that everybody being in a lecture like yours is evidence to that fact. You teach everybody the same way so that everybody's on the same page and everybody's a really highly informed critical care provider. So I think that was just some evidence to that fact, and part of the reason why I think this conference is pretty cool.
That's a great point. It's certainly all about the team. And though we're discussing complex topics in anatomy, physiology, hemodynamics, it's about optimizing the team approach to the patient. This will be the last wrap-up podcast for CCTMC 17, but we would love to plant the seeds for San Antonio and CCTMC 18 coming up next year. Dr. Fullagar, our IPP.
All right. San Antonio next year the CCTMC conference will be here again, April 9th to 11th, 2018, right here in the Wyndham San Antonio Riverwalk Hotel. So I really hope to see you guys there. It was an outstanding conference this year, and I thank everybody who has participated and who has attended.
And with that, it is late in the evening and we all feel obliged to consume adult beverages. This is the AMPA crew wishing everyone a safe tour.